Let's go over the classification. Essex Lopresti originally classified calcaneal fractures to embody either the joint depression or tongue-type fracture pattern. So the calcaneal tuberosity avulsion fracture fits under the category of an extra-articular form of tongue-type fracture that was discovered after Essex Lopresti's original classification study in 1952. So the mechanism of a calcaneal tuberosity avulsion fracture in younger patients, it tends to be a high energy mechanism in which the lateral process of the talus is forced onto the calcaneus via an axial load. Yet in elderly patients, this fracture usually occurs with a low energy mechanism with dorsiflexion of the foot and contraction of the gastrocsoleus complex. So these fractures have a potential for a poor clinical outcome. The Achilles tendon pulls force on the calcaneal tuberosity, which is like the floating fragment that sticks out at the top. There's skin blanching. The standard of care is to immediately do open reduction internal fixation, but failure rates are as high as 27 to 40%. Patients with failed fixation tend to have osteoporotic bone. Low energy mechanisms are therefore associated with poor bone quality. Risk factors include osteoporosis, osteomalacia, diabetes, and peripheral neuropathy. So we think that these patients with low energy mechanisms and comorbidities who are older may do better with an ostectomy and tenotomy rather than traditional ORIF. So we propose a method of complete excision of the superior bone fragment and release of the Achilles tendon from any point of attachment. This removes the need for 6 weeks of non-weight bearing. So they only need to stay non-weight bearing until the wound is healed. Adjacent musculature often compensates for the loss of the Achilles tendon as a plantar flexor. And again, these are low demand patients, so it's not like they're running marathons or riding a bike every day. This method will hopefully decrease reoperation rates, wound compromise, and infection. So let's go over a case. So we had a 65-year-old female present with morbid obesity, and she presented with a chief complaint of right ankle pain resulting from just a ground level fall. She had a past medical history of AFib, chronic kidney disease, type 2 diabetes, hypertension, heart failure, and hypothyroidism. We got x-rays. They showed a closed, displaced calcaneal tuberosity avulsion fracture of the right heel. She was told to follow up with an orthopedic surgeon, and she failed to do that and presented 4 days later complaining of right foot pain again. During that time, physical exam revealed erythema along with active bleeding noted from a deroofed blister on the heel, and a displaced fracture fragment was palpable. So the patient was scheduled for urgent ORIF for concerns of progressive skin necrosis. This is her x-ray. As you can see, like that piece is right up against the skin there. This is a clinical photo of her right heel. So for open reduction internal fixation, an incision was made lateral to the blistered skin and was extended proximally, and then a stab incision was made on the plantar surface of the foot. The fracture was successfully reduced with a pelvic reduction clamp and then confirmed by fluoroscopy. 3 guide wires were placed through the bone fragment and into the plantar surface of the calcaneus, 1 piercing through the Achilles tendon. 4.5 millimeter and 2 4 millimeter cannulated partially threaded screws achieved the fixation. Upon 2-week follow-up, the patient admitted to bearing weight on the right lower extremity, despite being counseled to remain strictly non-weight bearing for 6 weeks. Ulceration was noted on the posterior heel, and the Achilles tendon was exposed. There were no signs of erythema, active drainage, or infection. Motor function was maintained to the posterior muscle group. Radiographs revealed superior displacement of the fracture without hardware failure. She was assigned wet to dry dressing changes after that. So here it is. You can see the hardware is still in place, but that fragment let off, and that's because the Achilles tendon force is just so high. And if you don't have proper osseointegration yet, the Achilles is going to take that piece right off the bone. Okay, so she was readmitted 5 days after that office visit when she was assigned wet to dry dressings, complaining of worsening pain in the right heel. So she failed to complete these wet to dry dressing changes at home. She admitted to being non-compliant with weight bearing and pressure restrictions. She had been putting like a pillow under her heel when she was resting. Her skin was warm to the touch. The heel was edematous. There was no evidence of active purulence or infection. Then there was exposed Achilles tendon and bone. So what do we do now? We obviously can't do ORIF again. So the patient underwent removal of the hardware, excision of the bone piece, irrigation, and debridement. We took the superior piece off in a piecemeal fashion until no remaining prominence was present to blanch the skin. The Achilles tendon was not advanced. Enclosure took place using 3/0 nylon vertical mattress sutures. During the post-op period, she was assigned wet to dry dressing changes in non-weight-bearing orders until the wound healed. OR cultures grew Corynebacterium species. She was started on the proper antibiotics for that. On post-op day 2, she was able to rise to a stand and use a front-wheeled walker to take steps. She was discharged with a front-wheeled walker and was capable of plantar flexion, dorsiflexion. 2 weeks post-op, the wound base contained red granulation tissue and scant serosanguinous discharge and no odor. She remained hospitalized for 1 month due to renal failure and acquired mobility impairment due to her critical illness state. 5 weeks post-op, the sutures were removed and the wound was healing. The patient was admitted to a skilled nursing facility due to all of her comorbidities, and any form of mobility at that point required 2 assistants. But that wasn't due to our surgery. It was due to just her terrible kidney disease and other comorbidities. So her complex post-op story really illustrates why ostectomy and tenotomy are the simplest management strategy possible for these low-demand, high comorbidity patients. Okay, so then we had another patient present following the first one. About a month later, she was a 65-year-old Caucasian female. She presented to the ED 2 days after right heel pain. Her past medical history included type 2 diabetes, uterine cancer, psoriasis, pneumonia, ovarian cancer, osteoporosis, obesity, neuropathy, kidney stones, hyperlipidemia, breast cancer, arthritis, and acute respiratory failure. So 3 months prior to this, the patient underwent ORIF for a right displaced and dislocated trimalleolar fracture. She reported bearing weight on the right foot while descending stairs, and then she had the onset of the pain. Radiographs revealed a right calcaneal tuberosity avulsion fracture, along with failed ORIF of the previous right ankle fracture. So you can see her x-ray on the right there. So on physical exam, her right foot was swollen, there was ecchymosis, it was tender over the heel and the Achilles tendon, as well as calcaneal fragment prominence. She was referred to our orthopedic trauma team from the outside facility she presented to, and she underwent her surgery 6 days after her original fracture. So she underwent excision of the superior calcaneal fracture fragment and removal of the hardware from the right tibia. Fibular fixation did not fail and was left intact. Due to skin necrosis on the central aspect of the posterior heel, a proximal incision was utilized to access the bone fragment. The Achilles tendon was retracted from its insertion point and the bony fragment was removed. The 2 screws that were now intra-articular from her previous surgery were removed through the previous medial incision, while the remainder of the tibial hardware was left intact. She received non-weight-bearing orders for the right lower extremity until the wound healed. So for her, we primarily did the ostectomy, tenotomy, rather than ORIF. So on post-op day 1, the patient was noted to have intact dorsiflexion and plantar flexion with her baseline sensation intact. No growth from OR cultures. She was discharged home 2 days after surgery with a front-wheeled walker. In the clinic 2 weeks later, she presented in a wheelchair and had not been participating in her formal physical therapy that was prescribed to her. But her wound appeared to be well healing, no signs of drainage or infection, and her sutures removed with steri-strip placement. Her plantar flexion and dorsiflexion remained intact. 2 months later, she presented to clinic in a wheelchair, and the wound was well healed. There was a clicking sensation appreciated upon dorsiflexion and plantar flexion, but this is attributed to the patient's previous right displaced and dislocated trimalleolar fracture, which had not yet healed radiographically. She wasn't a candidate for further surgery due to her uncontrolled diabetes, and she was deemed unlikely to improve in her quality of life, given her lack of pain and household ambulator status. She was sent home with orders to begin weight-bearing on the right lower extremity. 5 months, she was able to walk by wearing a brace on the right ankle, and she began to drive again. So this is her 2 months out from surgery. And so there's been many efforts to put forth this tensile strength of the Achilles tendon that causes this posterior heel blanching, so trying other methods rather than ORIF. There was one study in which washers were used to increase screw purchase and compressive forces, which is also done in femoral neck fracture studies. And this method retains fixation, but the implant is not widely available, and it requires increased soft tissue dissection. Other authors have advocated for the use of suture anchor fixation, in which the Achilles tendon is adhered to the inferior calcaneus via a locking loop technique. But Cousin et al. Compared the use of screws with and without suture anchors in a biomechanical study of cadaveric specimens. Lag screws failed at 251 newtons and suture anchor augmentation at 441 newtons. So that being considered, the Achilles tendon actually acts with a tensile force between 1,962 and 2,354 newtons during gait. So these patients are still at risk for detachment of the tendon from the sutures, if not given strict mobility precautions. Another widely accepted method is to try tension band wiring for fixation, in which the Achilles tendon is adhered to the inferior calcaneus using K-wire and soft wire. But patients with this method have experienced discomfort wearing shoes due to prominent hardware, which creates the potential for skin necrosis as well. Interestingly, these methods get more and more eccentric. Ernst et al. Sought a biomechanically favorable approach by mimicking the hurricane strap. So the hurricane strap is used on houses to transfer the high velocity winds from the roof of a building to the secure foundation below, resisting roof uplift. So when you use this on the calcaneus, the only way for loss of reduction would be complete cutout of the plate, or for the superior bone fragment to cut through the dorsal plate. And this is a pretty advantageous method, but it requires an extensile approach, which has been associated with wound healing complications, which was also noted in that case report. So all in all, maintaining reduction of a calcaneal tuberosity avulsion fracture is challenged by the powerful force exerted upon the bone fragment by the Achilles tendon. Knowing that osteoporotic bone may have an increased failure rate for these low-energy fractures due to Achilles pull and inability for patients to be non-weight bearing, excision of the fracture fragment and tenotomy of the Achilles may be a viable option. This method of excision and release may allow for decreased risk of skin compromise and return trips to the OR for failed ORIF. In low-demand patients with low-energy calcaneal avulsion type fractures and osteoporotic bone, this surgical technique may be considered as a viable treatment option with better prognosis and less risk of post-op complications. These are my references. Thank you.